Good afternoon. Well, one of the advantages of coming a little bit later in the programme is all the experts get to talk about all the hard stuff, and I can just talk about the bits that I kind of know a bit more about. My brief today is to talk about the toothy bit, because as you know, the villain that Peter Selby talked about earlier on has similar impact on tooth substance as it does in bone. Now, when I say tooth substance, I mean not the crash helmet of enamel on the top, I mean the dentine inside, the tissue that makes up the body of your teeth, if you like. Okay. It also has an impact on the glue on the roots of your teeth that hold your teeth in your sockets, and it also has an impact, obviously, on the alveolar bone of the jaw. Okay, so it has an impact on 4 hard tissues and also the suspensory ligament, the little string bag that your teeth sit in, that allows you to have this wonderful tooth suspension system in your jaws. Okay, because your teeth aren't fixed into your jawbone, they all move individually. Okay, and there's very good reasons for that. It's so that you can cope with day-to-day pressures and forces of chewing. Okay, so it's a natural physiological advantage. Okay, so here's what the experts say happens in the teeth. So I said bone is very similar to dentine, the main part of your tooth, but there's a key difference in that all of the disruption that happens with the hardening of the teeth happens at the time when the teeth are forming. Now you might be thinking, yeah, that's a no-brainer. But in bone, the mineralization issues continue. I think I'm right in saying that. Whereas in teeth, the mineralization issues, the hardening issues only happen while the teeth are actually forming. So once the mineral is in your teeth, it doesn't come back out again, it's fixed. Okay? So what does that actually mean for us? It means that we see a very unique picture in the teeth themselves, and you know all about this, I'm sure. So we see very, very thin enamel, like the crash helmet of the outer part of the tooth has tiny micro cracks in it, invisible to the naked eye. The dentine, the main body of your tooth itself, is softer. It has what we call interglobular dentine. If you think about how dentine mineralizes, it starts off as a kind of jelly mass, jelly lump, little tiny one. And you know when ice forms, you know when you see those movies, when you see ice crystals forming and they grow and they grow and grow and grow? Well, dentine mineralization happens a wee bit like that. Okay? So because of the difficulties that FEX causes, that process doesn't happen to its full extent, so you end up with a greater proportion of the softer part of the tooth matrix being retained within the crown of the tooth. So it is softer, it's more bendy, and the bits that are mineralised don't join up as well as they could. Okay, so you get a reduction in strength. We have these really big nerves in the teeth with little tiny offshoots that again are invisible to the naked eye, that come right up to the very surface. And this is one here that comes right up to the very surface. So it's sitting under this very thin layer of enamel on the teeth. So day to day wear and tear could very quickly expose those nerves, and that's why you get the dental abscesses, because then that's an open door to bugs to get in and ultimately kill the nerve. So that's why you get dental abscesses completely in the absence of any decay or any erosion on the teeth. Okay. The other thing to tell you about, and it's the bit that often gets missed, we can be very tooth focused as dentists, not surprisingly, but FEX mutations also affect the suspensory ligament that fits around your teeth, and it also causes a greater proportion of periodontal disease. So if you have XLH, you're more likely to experience more advanced gum disease, as well as the actual tooth defects themselves, okay? So what does that look like? Here we go. So we've got child at 10, normal. These are baby teeth, baby molars, and this is a permanent molar. And then we've got a typical picture of XLH. Okay, we can see very, very thin, spindly roots, ginormous, big pulps, thin enamel on the top. That's the little calcospheroids, the little bits of aberrant mineralisation, the bits that haven't quite joined, the dots that haven't joined up, if you like, okay? So at this sort of area where the dentine meets the pulp, it should look like this. This is no accident, I'm wearing this top today. So peppered with lots of little cells, with lots of really hard stuff in between. In XLH, that's not the case. The spaces would be wider, they'd be more white and less bluefin, okay? So, clinically, this is a typical picture, and you've seen some beautiful pictures of abscesses before, and as you've heard, most of the time an abscess is a bad idea or a bad news sign, but sometimes it can be a fortunate sign. Okay. So studies have shown that in terms of gum disease, adults, between 60 and 70% of adults with XLH have some form of gum disease. They think that's to do with the cementum, the glue layer that coats your teeth, because the little ligaments, the little fibres in your ligaments that attach your teeth to the bone don't mineralise at the ends, so they think that's why that happens. So the attachment gets lost very quickly and the bone disappears quite quickly as well. Okay. So obviously you are dealing with a sizable problem and a sizable burden of care. A recent case series review that was done in the Children's Hospital showed us that about 70% of patients currently under treatment had experienced dental problems by the age of 5. And about 57% of those had presented with a dental abscess at some point by the age of 5. Now that's a big problem for you, but that's also a considerable problem for me, because that means that I'm dealing with my customers are not going to be the most keen on coming to the dentist, not the most compliant, so I'm going to have to take you through all sorts of options for anaesthesia and sedation, simply to get a problem managed. Okay, so there has to be quite a bit of discussion, two-way discussion about the right modality of treatment for you or for your child. So medication for XLH is a fact of life. It's part of the condition, it's part of how it's managed. As dentists, we need to be conscious of that. So I was asking myself the question, okay, we know that the medication really helps with the bone and all the other issues. What does it do for the teeth? Does it help the teeth at all? Given that we know that baby teeth don't change, but then by the time XLH is diagnosed in infancy, there's a theoretical chance that the medication could have an impact on developing permanent teeth, because they're growing during that time, certainly during that first 5 years of life. Okay, so there's a theoretical chance. And the research would actually suggest that there is an improvement with full compliance with regular medication. So I thought it was quite interesting to kind of look at it in terms of when treatment begins, because that's the critical thing. So if treatment for the XLH begins when teeth are developing, then there is a chance that things can actually improve in the adult teeth. And that's why you don't see the same severity of problems in the permanent teeth as you do in the primary teeth. Because in the primary teeth, it's already kind of fixed. Nothing's going to change that, because primary teeth start to develop whilst the baby's still in the womb, around about the 6th week of intrauterine life, right up to about 4 months. Okay, so by the time baby's born, teeth crowns are pretty much there. Nothing's going to change that in particular. Okay, but the only adult teeth that are developing at that time, right at the time of birth, are the first permanent molars. So there's more hope for the permanent teeth. Okay, and we think that's what we're seeing. And there's also been reported a small study that looked at the advantages for regular treatment on the periodontal attachment loss, and that again seems to be very, very beneficial in adulthood. If treatment starts later, or if there are issues with compliance with regular treatment, then the severe dental problems persist into adulthood. Okay. And this is just more evidence, really, from the sort of adult perspective. I'm a children's dentist. I don't get to see my patients grow up and move into adulthood. So, you know, I have to go on what my esteemed colleagues tell me, what you tell me about your experiences in adulthood of complex dentistry and lots of root treatments, etc. But this is another study that kind of puts the case for regular and early treatment and really good full compliance with treatment, because there's a bit of a spectrum happening here. So you can see that it was looking at bone loss and gum attachment, but I thought it was useful just to show you things like abscesses as well. So this first x-ray is someone who has had intermittent treatment in childhood, maybe started late, or but just not full compliance. This one is someone who did comply fully with treatment that was started in childhood, and then this one is someone who had gold standard compliance with treatment throughout childhood and adulthood. And I don't know if you can perceive the difference. There's less root treatments and things going on there, and there's less abscesses. So this, if you like, these are the two ends of the spectrum, and that's pretty interesting, isn't it? It gives you a bit of hope for at least for the dental bits. Okay, but there are so many things that make outcomes unpredictable. So we can't really just say, well, because you're on regular medication, that's it. All of your dental problems are going to be resolved. Okay. So I never miss an opportunity to talk about prevention. And really, for me, good oral health is the cornerstone of general health for everyone, but in particular for people with complex disorders like yours. Okay, so knowing what you can do to prevent the preventable is absolutely key, I feel. So what I'm going to do is I'm going to talk a little about active prevention of dental diseases, because dental disease is common, and by dental disease I mean these. So which ones of these do you think are preventable? Are there any of those dental conditions that you think are completely preventable? They all are, absolutely. They all are. They all are. But they're also very, very common. And any of these conditions on a background of an already vulnerable tooth or vulnerable dentition, is really not a great picture. Okay. So, we all know this. You know that, Finn, don't you? Yeah? Black plus sugar equals grot. Yeah? Did you know this? That dental disease is the most common reason why children receive a general anaesthetic in the UK, and that still holds true today. And that's not an XLH, that's generally speaking. Okay? So, by the age of 5, the general background is that more than 40% of all 5-year-olds in the UK will have experienced some form of decay. So it's very prevalent. So it's even more vital that we know what we can do to help you prevent it. All right. So you know all of these. You know all of these things, and in particular, you know what happens when you have an acid attack. You know what happens when you eat something. Yeah. When you eat something, you have an acid attack. So the bugs in your mouth produce acid. They have a feast on whatever you've put in there. pH in your mouth goes down. That allows the mineral in your teeth to come out into solution. Okay. And after about 20 minutes, your own defences kick in. The saliva brings it back up again. Some of that mineral will go back in, some, but not all. All right. So generally speaking, if you have breakfast, lunch, and dinner, you can cope with that, no problem. If you have a couple of snacks in between, yeah, system can usually cope with that as well. Okay. If you're having much more frequent intakes of sugar, that's when things start to go awry, because your mouth never really ever fully gets back up to where it was before. It never gets up to neutral again. It always stays in the sort of acid range. Okay, and that's when decay happens. And that's when erosion happens too. All right. So one of our big oral health messages is snacking infrequently, sugar restriction, yeah. So it's not as much about quantity of sugar, it's more about frequency. Okay. So if you're going to have a great big bag of jelly babies, save them up and have them after your dinner fin. Okay? And eat them all in one go. That's okay. All right. Okay. So I thought I'd share with you some of the questions that I get asked a lot of. Okay. And Nozomi's daddy asked me this question in the dinner queue earlier on as well. So which toothbrush do you think's best? So you've got a conventional toothbrush or you've got an electric toothbrush? Have you got any preferences yourself? Hands up who thinks an electric toothbrush is best. Okay.
Just the opposite.
Okay. And hands up who thinks you can do just as well with an ordinary toothbrush. Yeah, it's about 50-50. My answer, whatever makes you brush your teeth is the best. In children, you can read all the research about electric toothbrushes, usually sponsored by the makers of the toothbrushes. I'm made a bit cynical there. However, as I said to Nozomi's dad earlier on, you can spend £2 on a Spider-Man toothbrush that will make your kid brush his teeth as often as you want them to, or you can spend £75 on a novelty that might sit in the cupboard and never get used, like in our house. Okay. There we go. Yes, dentistry has gone digital, unbelievably. One of the questions I ask myself is, how do I stay motivated to brush my teeth and keep my oral health good and watch my diet? And that's what I mean, really. And how do we continue to motivate our kids? Well, these are just a couple of my favourite dental apps that are out there, and I don't know if any of you seen these. The first one is the Change for Life Sugar Smart app, and you can download it on your phone. See some nods. Yeah. So there's one that does. You can basically scan the barcode of any food or drink, and it will tell you in really stark form how many sugar cubes the sugar in that product equates to. It's great fun. I really recommend that you do it. There's one that just does sugar, and there's one called Food Smart, which does salt, fat, and sugar. So that's a triple whammy. That's a really good one. Okay, have fun with that. You'll be absolutely horrified with some of the amount of sugar in some things. And you can see this is one I did just for Finn. The jelly babies I was talking about. Yeah, maybe we should skip the jelly babies, Finn. Maybe we'll skip those. Okay. Brush DJ, have you heard of that one? All the dentists in the world will tell you, brush for 2 minutes. 2 minutes is a long time. It's a really long time for an adult. It's a really, really long time for a child. 2 minutes. That is the golden time. So why not make it fun by downloading something on your phone that can play a bit of your favourite song for 2 minutes? That's got to be better than sitting with your watch and here we go. Okay, so I'd encourage you to have a play about with things like that, just as motivational aids. And I thought I'd put this up because it kind of occurred to me after listening to Sue, and yes, it was me that took out all of Jacob's teeth. I'll just fess up right now. I have apologised to him, by the way. I also took out a lot of Finn's teeth, as you'll see later. But when Sue mentioned about how she used to get her children to take their supplements in cordial, it occurred to me that, that's something that we really need to think about working around or working with you on as dentists as well, because there's no point in me saying, don't drink this, that, and that. If that's the only way you can get your child to take their supplements, we're going to have to work with that, aren't we? Okay, but what I would encourage you to do is try and choose sugar-free things, okay? And it's only sugar-free if it says the words sugar-free on the label. There's a lot of things that say no added sugar. That's a bit of a con because it means there's already sugar in it. They haven't needed to add any more refined sugar. Okay, so this is up in our waiting room in the dental health unit at the moment, and I'm really rather proud of this because actually I found it quite horrific that Vita Coco, the coconut water that I thought was really healthy, has so much sugar in it. But scary, even flavoured waters, 23 grams of sugar. Okay, Volvic do. There are other waters are available. Volvic do a sugar-free version. Okay, so just a little bit of food for thought there. Okay, so in terms of treatment, things have changed quite a bit. I came to Manchester in 2006, and I probably did some things then that I wouldn't do now. But you know, much like medicine, dentistry evolves, maybe slower, but it does evolve. And things have really changed in terms of the materials that are available to us, and also how we use old materials and new techniques using old treatment modalities. So one of the ways that I have found to work in my hands, and my colleagues around the country are switching on to this as well, is that we can actively prevent dental abscesses in primary teeth and in adult teeth as well, but with a bit of intervention. Now there's a balance, and we have to have a discussion about the pros and cons of getting treatment done as opposed to not doing any treatment, as opposed to maybe waiting until we've got a problem we need to manage and then sorting out lots of different other things at the same time. Okay, so I just wanted to share with you how my practice has changed a bit and what I'm tending to advise parents that we can do, not that we will do, because that's your decision really at the end of the day, but what we can do to help put off or avoid completely the formation of abscesses in children's teeth. And it all centres around covering them up. It's that simple. So protecting them and preserving them as soon as we can. For the front teeth, that means painting on sealant or flowable composite material. It's white, it's invisible once it's on, it seems to work, it sticks onto the teeth. It's relatively easy to put on. It doesn't need a lot of compliance, but it does need some, okay? And it's only as good as the bond between the sealant and the tooth has to be dry to make it stick, okay? The materials we can use nowadays they're strong, they're much better than they used to be even 4 or 5 years ago, but it's a bit, you know, they do wear and they do need to be topped up on a regular basis. So once you go down that route, you're looking at an MOT and a service, you know, on a reasonably regular basis, okay, because they do wear. Do you recognise anyone in that photo, Finn? I didn't take all your teeth out. I left you some, okay? That's the proof, all right? Can you see the sealant on those teeth? It's pretty good. Yeah, and all you need is a very, very thin layer bonded on. And there's evidence from various researchers around the world to say that that works. So I'm really pleased with that. Okay. What about the back teeth, though? Well, yeah, we can put sealants on back teeth, but as I said, back teeth are going to be more prone to wear. They're going to be more subject to the stresses of chewing than the front teeth are, really. So in my mind, I need to do something a bit better than that. And we can with a little bit of a tweak of an old technique. Some people used to recommend, there used to be a dilemma about how you would treat primary molar teeth in young children with XLH. And the issue was we wanted to cover them up with these preformed crowns, which have been around forever. But you had to make space for that preformed crown to be cemented onto that tooth. So you had to cut the tooth to do it. And we know, given the structure of those teeth, there's a huge risk that just simply shaving a bit off those teeth to make the room for those crowns could actually cause the dental abscess you're trying to prevent by exposing the little tiny nerve offshoot. So that was the big dilemma. Okay. However, a dentist in the north of Scotland, about maybe 6 or 7 years ago, started putting these little crowns on. They're used to prevent decay, they're used to treat decay. Started sticking them on kids' teeth without taking away the decay, without any local anaesthetic, without any kind of decay removal at all, and without any kind of prep of the tooth, and it didn't cut anything away. And she found that she had predictable results, and kids didn't sprout abscesses. So the dental experts, my esteemed colleagues, picked up on this, and it has now been the subject of a huge clinical trial across the whole of the UK, looking at the benefits of sticking crowns on grotty teeth without doing anything else. Provided you choose the tooth carefully and there's no pre-existing abscess there, okay? And the results are fabulous. It really, really works. And we know these things, once they're on till the tooth falls out. And that is the big advantage that I can see, because you do it once, you do it well, and that's it until the tooth falls out naturally. Okay, so that's got to be better. Yeah. So this is one of my cases. So this is my results, really. Started off with typical XLH appearance to the primary molar teeth. Decided we were going to go down the active prevention. I was going to actively intervene to stick something on those teeth. I wasn't going to wait for an abscess. That's what we did. Okay. So we put crowns on each of these back teeth. This was done in the dental chair. This wee girl didn't need to go to sleep to have this done. And she came back for a number of visits, and we were able to do it. And the way that we did it was we borrowed a technique from our orthodontic colleagues, where you put a little plastic donut in between the teeth. You know, when you're having braces on, I don't know if any of you remember having braces on, if you ever did go through that torture. But you put little elastic bands in between teeth, it very gently over a short period of time nudges the teeth apart just enough for you to be able to get a band, or in our case, a crown, down, and you glue it on, and that's it. Okay. So that's what we did with her. So that was her in 2014. In 2015, she came back, no abscesses. I'm looking down here because that's where the abscesses are usually. And in 2016, I'm due to see her soon, still no abscesses. So that's a 4-year, hopefully 5-year success rate for that one lot of intervention. So that's tending to be the approach that I'm advising these days. Okay. There was a time when the only thing we could do is the only predictable way of completely preventing an abscess in a primary tooth was to take the tooth out. And that was the perceived wisdom at the time, and that's why some of you may have experienced that. But I wouldn't do that these days. I would explore other options because I have a more predictable option. I have a real option now. Okay. So what are the sort of treatment principles then in the adult teeth? Again, because I'm not an adult dentist, I'm a children's dentist. I don't have very many pictures to show you, but the principles are the same. They're pretty much the same. And in some ways, as Peter said, the dental problems are less difficult to deal with than they are in the primary dentition. Okay? So there's a number of papers out there that suggest that conventional root canal therapy, crowns, those are the treatments that can be done And they work and they're predictable, and certainly my look through the recent literature suggests that that hasn't changed at all. So yeah, that's pretty much it from an adult's point of view. In both the adult teeth and the primary teeth, one of the most important things I think though is managing dental abscesses promptly, and that's to avoid excessive loss of bone around teeth, which is the whole thing we want to completely avoid if we can. Okay. But we do take out teeth when we need to, both in the adult and in the primary dentitions when it's completely appropriate. There we go. So I've talked about how we can give you advice about preventing the preventable, so that you know basically what you can do. How can then we help? Most important thing I think is early contact with your local dental services. Specialist dentists, so get to know who your specialists are in the area, and hopefully your clinicians will know who to send you to. Certainly, I'm very I consider myself very fortunate that I work in the same hospital as Zulf, but we have quite a big dental network. So you have specialists based in hospital and you have specialists based in the community. So some of you might be under the care of local community dentists, and that's fine. And by community dentist, I mean someone who's based in a health centre. They tend to be people who have additional skills, a lot of experience in managing children and adults with additional needs, complex needs, and they're what we would term a lifespan service. So if you're under the care of a paediatric dentist or a high street dentist, I think it would be in your interest to seek out the possibility of a referral to your local community dentist as well. Okay, and certainly if any of you come through my clinics, then I would ordinarily suggest that we put that link in place for you as a matter of course. Okay, and if any of you ever find yourselves in the situation where you can't access dental care, if you can't find an NHS dentist in your area, then the community dental service would be your best bet, and your GP can refer you to them as well. Okay. It's vital, obviously, to do what we do. We have to have very good communication with your medical carers, so that we can provide the best care at the right time for you, and do what's in your best interests, provided that those two things, our expectations or our perceptions of what we think is in your best interests, match up with what you perceive to be in your best interests. Okay. And really, at the end of the day, the best thing that I want to do really is to empower you to make healthy choices for your own oral health. And I hope we can do that in discussion and in partnership. So thank you for listening. We get to know your dentist. Can't promise to be as entertaining as this guy, but if you ever get the chance to watch him on YouTube, he's fabulous. And he gets the messages across in a really fun way. So thank you.
We've been really lucky and we haven't had any dental problems. But do you think we should go back to the dentist and ask for something preventative, even though they haven't had any problems?
How old are your children?
Pardon?
How old are they now?
7 and 12.
7 and 12. Yeah. So, that's great. You've done very well, I guess. I think if you got this far, what I would always say is, if there's a risk, no matter how big or small it is, if you perceive that it's a risk, something you would be concerned about, then yes, I would encourage you to go back to your dentist. Because there's no reason why your dentist can't apply sealants to permanent teeth. It's standard practice, actually, standard prevention practice for everybody, that fissure sealants are applied if a child's oral health is compromised or it potentially could be in some way. And I think as Zolf said earlier, you know, there is a spectrum, and so there will be kids at one end who have a relatively mild expression of the problem in their oral health, compared to the opposite end of the spectrum. And I would say probably Finn had one of the most severe forms that I'd seen. The structure of his teeth really, there's hardly any roots on those teeth when we saw him at first, wasn't there? You know, so I think if it's a concern to you, then there's absolutely no reason why you shouldn't ask. Yeah.
A 12-year-old, she's waiting for braces.
Yes.
If she has braces, is there an increased risk of abscesses?
That's a great question. I don't know the answer to that, to be honest. I wouldn't. I don't know the answer. If there shouldn't be, if her teeth are healthy, if her brushing habits are ace, and they have to be, you know, for braces these days anyway, as orthodontists don't do dirty teeth at all. So she shouldn't be at any greater risk of abscesses, provided all the oral care is optimal.
Okay.
Yeah.
Thank you. Can I ask a question?
Right.
You talked about caps on teeth.
Yeah.
Sorry, can I just get you to clarify the difference between baby teeth and permanent adult teeth? So, like, for my children, you know, like, obviously I've got a baby, a 20-month-old, and I've got a 9-year-old.
Yeah.
You never mentioned about late dentation, which I think you do get with this condition. My daughter seemed to get teeth a bit later, and also the falling out of the baby teeth. Is that something that you know about, or is that more the doctor's side of it? Because my daughter's got a lot of baby teeth still, where all the children in her class have got a lot more adult teeth.
Yeah,
and should I be more bothered about the care? Obviously, I don't want her to get abscesses as a child, so do I want her to have these crowns on her baby teeth? She's now starting to lose some of her baby teeth, and she's got like some adult teeth coming through, like I say, later than the other kids. Yeah. She doesn't see any specialists. Yeah. In fact, she doesn't really, you know, she just goes to the dentist with me and they have a quick look at her teeth once a year.
Has she ever had any?
She's never at this stage, touch wood, had
good.
any abscesses and doesn't appear to have any issues with the teeth. Yeah. But we're talking about preventative, of course. So
that's true.
So could you just sort of clarify what you were talking about? What's for baby teeth and what for adult teeth of children with XLH, please?
Well, the baby teeth aren't going to be there forever. I guess that's the difference, isn't it? So you've got to look at when they're designed to fall out anyway, and how long they've been there and they've stayed healthy, and what you can get away with, I guess. And again, it's a balance of risk. And if she's not had any abscesses just now, I can't really categorically say she'll never get an abscess. I can't say that. But every day she's getting closer to the point where those teeth are going to shed naturally. Okay? Whereas the adult teeth, you've got them for life, ideally. Okay? And in order to keep them for life, they need a little bit more TLC to ensure that they stay that way, I guess. Yeah. Does that answer your question?
Yeah, so we're talking about I should really be going to the dentist and going, you know, she should have a sealant on the front teeth, and, you know, should I be talking to them and saying about caps on the crowns, you know, do I go to Leeds Dental Hospital?
Yeah.
Does she go to a normal private dentist? You know, they're not really educated in this condition.
No,
My dentist, I've had to tell him about why I've got needed root canals and why, for some reason, I don't have as longer bones. I've had to educate him, you know, because he had no understanding at all. Yeah. And why I've got gum disease. He's telling me I've got gum disease because I used to smoke. But, you know,
now you know it's part of the condition. It's a very real and often overlooked part of the condition.
So should I be looking to my consultant, you know, at the hospital, the endocrinologist that my children see, to refer me to the dental hospital?
I think that would be helpful.
Yeah.
I do. Yeah.
Okay, thank you.
I think in our hospital, every child with XLH gets automatically referred to dental services. I don't know whether the same happens in Birmingham, Nick.
No, but I think.
It doesn't happen in Leeds.
But I think it's a good idea.
It doesn't happen in Leeds, which is where I am.
Yeah.
We see.
It varies across.
Every 6 months, but we've never.
There's a superb doctor.
Yeah, who's a superb doctor.
But it varies across the country.
Problems, so.
And I'm not saying that every high street dentist couldn't treat anyone, you know, anyone should never ever treat. I'm not saying that at all, absolutely not. But specialists like who are based in hospitals, dental hospitals, children's hospitals are more likely to have seen other kids and other adults
Yeah.
with the same condition and will have a bit more experience. And every individual is different, that's the other thing to say. So although I hope it didn't come across that I think everybody should have crowns on their teeth, that's not at all what I intended to say, but it's an option I can offer in terms of actively preventing something happening.
I think prevention of dental abscesses is quite important. There's another young man sitting in the audience who's an ex-patient of mine. I was at a meeting in States, and I had an email from my secretary to say that, you know, this young man had been admitted with massive sort of maxillary abscess, you know, so it can sort of spread and cause massive sort of swelling of the things. He's a fine young man now. I'm not going to point him out because I don't have his permission to point that out, but I think so if we can prevent dental abscesses occurring, then I think it is advisable. My question to Kay is that, Kay, where you see families where they've got 3 or 4 children with XLH, and you find that some of them go through life without any abscesses, and some actually have more than their fair share of abscesses. Is it just down to dental hygiene or compliance with treatment, or just bad luck, or we just don't know?
It could be a combination of all of those things, to be honest. And the same is true in dental disease, the preventable dental diseases. So you can, within one family, you can have one child who needs to have loads of teeth out, multiple GAs just because of really bad teeth. And you can have siblings who don't have any dental disease at all. And sometimes it doesn't always follow that you've learned your lessons with your older kids, therefore things are better for your younger kids. It doesn't always follow. Sometimes it's completely the reverse. So there's so many, in terms of dental disease, the preventable dental diseases, there's so many factors that interplay that it's difficult to pin it down to one thing. But I think it's, at the end of the day, it's all about reducing risk. And if we know there's a predictable way of reducing risk, then that's what I would advocate.
So the group from France, who's the Paris, whose paper you quoted, they have shown some very nice data, which I think you've in fact alluded to, that treatment, aggressive treatment actually improves the quality of the dentin and thereby hopefully prevents the abscesses. The question is, the primary teeth are formed in the womb, and if you know that the baby is going to be born where there's very high risk of that baby developing things, and if mum is if it is possible to treat mum, do you think we should be optimizing treatment in utero to actually prevent?
I was going to ask you that question. I said, what do you think the impact is of treating mum? Is there a link? You know, do those kids do better? Do they have less severe oral problems? I don't know.
Oliver.
There's studies of that taking place last year in France. There were studies of that taking place last year in France, whether or not you decide to medicate the mother when the child is in the womb, and whether or not that has an impact on that child, and what kind of strain that has on the mother as well.
Sure.
I'm afraid you're going to have to look it up. I can't regurgitate it now, but yeah.
Thank you. Thank you.
Got one more. Did Kirsty, did you have a question?
Of two things actually. Our daughter's 3 at the minute. With the sealant, can any dentist do that? And the crowns as well, or does it have to be a specialist, or should she be under a specialist dentist already?
If you have a very good, very confident dentist who's confident in dealing with 3-year-olds and can confidently get those sealants on, I'd say stick with your dentist. In my experience, most high street general dentists will throw up their hands in horror at the very thought of doing anything to any child under 5. And in those circumstances, I would advise you seek a referral.
Is
So
she
your local-
too young to have this done, or
No, she's at the right age because hopefully all of her permanent molars are in now. Usually the permanent dentition is fully established by between about age 2.5 and 3. So if you want to do, if you're going to do a big hit, if you like, and start to introduce treatment, then this is the ideal time.
And is that get a referral to the people that you said?
Yes, so your own dentist or your GP could refer you to your local community dental provider, who may feel that actually you need to go and see one of the consultants in a local dental hospital or a children's hospital.
Okay.
But depending on where you live and what the postcode sort of geography is, then your GP or GDP would probably be in the best place to advise you about that.
Okay. Second question is, as an adult, are these treatments, do they just not work, or are they not available? So the sealants and the crowns.
Good question. They're certainly available. Are they necessary? I guess that's the question.
Do they do the same job? Because personally,
Should do.
I've had quite a lot of abscesses and had quite a lot of teeth out.
Sure.
So I suppose my question is, would they do the job for me?
Should do. I wouldn't advocate the preformed crowns, not in an adult mouth, because you want something much more permanent that's going to stay there. These are semi-permanent, if you like. They're only designed to last the lifetime of a baby tooth. Okay. So in terms of crowns, there's no reason, and this is conventional dentistry really, there's no reason why you can't have gold shell crowns or porcelain crowns on front teeth if it's appropriate, if that's what you want.
And the sealant as well, is that?
Sealant, absolutely. I mean, that's the least invasive thing you can possibly do. Yeah,
Okay.
absolutely.
Thank you.
Okay, one last question, please.
Thank you. You say we have to brush. I mean, the normal toothbrush and the electric are the same. How about the toothpaste? Which one is the best for?
Toothpaste.
Yes.
Yes, I didn't even talk about toothpaste, did I? We would advocate a high fluoride toothpaste. Fluoride is the dentist's secret weapon, and most adult toothpastes have 1450 parts per million. That's the magic number you should look for in a tube of toothpaste. But when there is evidence to suggest that fluoride therapy does enhance the hardness of the enamel, so theoretically should hopefully reduce the wear and tear on your teeth, which might then lead to exposure of those little micropulp horns. And so the rationale then is more is better. So as an adult, there are prescription toothpastes that go up to between 2,800 double adult toothpaste strength up to 5,000 parts per million. And because they are super strength fluoride, they have to be prescribed by a dentist or your GP. You can't buy them, over the counter, because they are technically a medicine. So yeah, you can use a higher fluoride toothpaste.
And in a child, there's no risk of fluorosis?
In a child, I wouldn't advocate a high fluoride toothpaste until probably I was absolutely certain that we were beyond the risk period for front teeth. I'm not worried about a little bit of fluorosis on the roots of developing sibilants, because it's not going to be a cosmetic issue. And fluorosis, I don't know if you know, but it's white patches or mottling on in the enamel, opacities in the enamel. So it's not something that's desirable on front teeth or anywhere you can see it. But if it starts, at a later date, the magic number on the 2,800 parts per million Durafat toothpaste is don't prescribe it before the age of 10. In my practice, because I deal with complex kids of all descriptions, I will usually prescribe it from about age 7 or 8. Once I know we're out of the danger zone, if you like, or the danger time for developing opacities on front teeth.
And given that Manchester water is not fluoridated at all, there's less of a risk, I suppose.
Absolutely.
Yeah. Okay.
Can I just sub your question a little bit? You mentioned about prescription toothpaste, but in terms of children, would it be recommended just to use an adult toothpaste rather than a child one?
Absolutely.
Okay.
Yeah, and that is what I usually recommend. Yeah.
Okay, are you staying for the panel at the
Yes.
end? Thank you. So any more questions? Kay will deal with in panel. Kay, thank you very much for that very enlightening talk. Thank you.